Sorry, you guys. Sorry for the technical issues. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Department of Training. Adult anesthesia critical care condition. Serving the medical director's office is car 609. On behalf of the medical director's office, Dr. Pollack, the EMS office, Director Shenning, Captain Willits, Captain Stewart, thanks for being here and supporting this effort. Welcome and thanks for what you do. Thanks for your commitment to lifelong learning. That's all for Ashley, Caitlin, Hunter, and Avi for helping live stream. That's great. Tonight we have Dr. Alistair Kent. Dr. Kent is a trauma surgeon at Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center. Dr. Kent's area of clinical expertise includes general surgery, trauma, surgery, critical care, and surgical care of critically fragile patients. Dr. Kent is an accomplished educator and researcher. His research interests include studies of healthcare delivery systems, healthcare economics, geographic analysis, trauma care, and systems of care for patients with life-threatening or time-sensitive illness. Dr. Kent actually also gave a talk for us on crush injuries that are available on the Pikesville YouTube site, and that as well was a great talk. So again, thanks as always for being so amazingly.
Thank you. All right, guys. Thanks for coming out. So this is a little bit of a different topic than you might be used to hearing about. This is less about how to treat an individual condition, more how to think about treating sums of parts. And I think when I usually give this talk to the medical or the hospital guys, it's a little bit different. I think you guys might have a more intuitive sense of this just by the nature of the job that you do when you go out there. So we're going to talk about trauma systems, and we're going to focus on the hospital resuscitation phase because that's where I am and what I do, and how that kind of fits in with everything else. And I know a lot of times that when you guys are bringing people in and dropping them off, there's a lot of differential experience of seeing what happens, knowing what those next phases are, and even knowing what you're doing when you're taking somebody that's just been injured and delivering them to the next phase of care, and then what you do and you doing it well helps them do better later on. So I drew this literally like 2 hours ago, and just scanned it with my phone. I figured this is about as good of a how to trauma diagram as any. Somebody gets hurt, they come in the ambulance, they come to the hospital, right? And then when they get there, so my thing works, maybe. There it goes. Then patient comes in, there's a gurney, and then lots and lots of things happen. There's lots of people, it's a big mess. And that's essentially the talk, you can all go home. So bleeding is bad. That's why we care about things that are efficient and time sensitive in trauma. The body can compensate and stay alive for some amount of bleeding, and obviously the more bleeding that you have, or the less physiologic reserve that you have, and that means if you're older, like more than 20, and have other medical problems. The thing is, it's really hard to know what that is, how much you've bled, how much reserve they have, how sick they are at baseline, or even what the injuries are without doing some looking, and that looking takes time. Look around, and even like in the hospital, looking, that can take up to half an hour, 45 minutes to actually just figure out where the injuries are. And in that amount of time, and I've seen it, that people can have severe life-threatening injuries and they're peri-arrest, and we didn't even know it for half an hour. And so that's the problem that we try to get at. And you hear about the golden hour, and we'll get into that a little more. And so how do you address that time problem? And obviously from your guys' standpoint, this is stuff you focus on a lot. You scoop, run, get to the hospital as quick as you can, waste a lot of time on things you don't need to do. Building a team is very important for this, and you can build these teams in layers. The other things that you can do is you can build protocols. Heuristics, the fancy word for it, just means things you've considered ahead of time in ways that you're going to have a known problem when you run into it. And obviously these protocols, they don't solve every problem, but you try to build them so that they solve most of the problems most of the time. So that, the 80-20 rule, the Pareto efficiency, we sometimes call it. And if you can get a protocol to do that, and then knowing when you're on protocol and then knowing when you're off protocol. The other things we can do, especially once we get to the hospital, our ability to do this is expanded, and that's physiologic support. This is the most expensive and the least helpful of any of the things. And that's blood transfusions and IV access and lots of fluids. And, if we're given epi and the setting of an arrest, that's sick hearts don't like it. Giving them blood and fluids and supporting them up and holding pressure and all that kind of thing. All of this is to build time to that point where we can definitively stop the bleeding. That's a clock that starts not when they get to the hospital or not when you pick them up, but when they were first injured. So you guys have probably seen this, right? This is the memes categories. This is just an example of one of these triage protocols. And it's an attempt to categorize, based on what you can see rapidly, how sick somebody is, or the probability. This is ATLS is what we use in trauma centers, and it's basically the same thing. It's to a couple of steps: a primary and secondary survey. There's a little more to it, but essentially, primary survey is figure out what's going to kill somebody in the next couple of minutes, and those are things like: are you breathing or not? Do you have a tension pneumo or not? And are you having a severe neuro problem? Are you herniating? Are you having a stroke, a seizure? And then just look at them. If they've got a big piece of flesh missing or a big cut or lots of holes in them, that's one thing versus if they look normal. Once you do that, then you can do some other things that take a little bit longer, chest x-rays and pelvis x-rays, looking for things that are, again, big, fast problems. These aren't like formal, very precise diagnostic studies. It's a quick and dirty. Is there a big, blood in the chest, hemothorax, pneumothorax that's going to need an intervention before you do anything else? Is the pelvis busted wide open and you need to put a binder on? The goal of all that is to see if you need to go to the operating room to fix whatever it is, you can go right then. You don't need to do anything else, and that should at least get those early time-sensitive problems that are very life-threatening out of the way. Now, if they're not hemodynamically unstable and there's not like major bleeding that you can't control with just pressure or a tourniquet or something like that, then you have a little more time. And then we do the secondary survey. So this is a slightly longer, slightly more comprehensive look at what happened, or to try to figure out what the injury pattern is. And it's a head-to-toe exam. We still have a time sensitivity to it. We're moving rapidly. But, this allows us to actually take a look at everything. We strip all the clothes off. We look at, take the tourniquet down, take the bandages off, roll people over, look in all the nooks and crannies in the armpits and the groin, that kind of thing. And think a little about what other studies that we might need to get, whether that's a CAT scan, formal series of x-rays, MRIs, etc. And then once we kind of have that information, we want to put them where they can get definitive care. Now, if that's like a complex car crash and they need to go to the ICU and get resuscitated and watched and basically sat on with that physiologic support for a couple of days while they clot off, or if they need to go to the operating room and get something, some ideal timings for how long that should take. Now, keep in mind, these numbers are not absolute. These are to be flexible based on what happens, but in routine circumstances, when the patient comes in, an amount of time to communicate the essentials of the situation is about 30 seconds to a minute. For most situations, that's going to be as much as you want. Survey the toe, looking for life-threatening things, again, about a minute. It's a lot faster than may have been seen. The adjuncts, a couple of minutes to do, rolling the x-ray machine in and out of the room, getting the ultrasound in and out. Secondary survey a little bit longer. The formal imaging, if you're going to go to CAT scan and sit there for 10 or 15 minutes while the scans are being done. Obviously, you want those life-threatening things out of the way before you do all that stuff, and they're in the room, in the tube, and then having a respiratory decompensation. And then really the goal is this down here is hemostasis again. From time of injury, about an hour is the longest you want to take. This is where the golden hour comes from. Initially this is for support to a trauma center, but really once they get to the trauma center, it's not the end of the story. It's once we get them to a point where the bleeding is stopped and we can actually catch up. So what is hemostasis? For spleen, take it out. Sometimes if this is in conjunction with other injuries, it's not severe enough to cause hemodynamic instability, we can clot these off using an interventional radiology procedure. The catheter goes up just like a heart cath, goes up to the spleen and squirts a bunch of stuff to clot the spleen off. We can do that with the liver too, sometimes with the kidney. Where you can see the hand here just pushing on these are the blood vessels coming out from the vena cava going towards the right kidney. And busted, but pressing on those vessels is one way to gain control. The other is just to pick the organ up and hold it, and that can keep it from bleeding. And then for livers, these are surgical sponges. This is actually a model, not a real liver, of a technique used to pack and then use the omental fat, which is just a fatty organ in the abdomen, to put into the liver to act as something to hold pressure. On the side over here, you can see the technique of that packing is you put sponges above and below and make a sandwich, and that sandwich is basically just like holding pressure everywhere on an organ that bleeds from everywhere when it's cracked. Looking at it a little different way, these are some live pictures. This is the sandwich packing. You can see sponge above and below on this little liver segment. This is a liver that's had it's a little hard to see with the glare here, but there's sutures in the liver to help hold that together around the packed sponge. And again, that's to kind of compress all that off and allow the bleeding to stop. Now these don't control it 100%, but they get it slow enough that they can then clot. But the point of this is all this takes time. This, to get to a point of when you're, let's say you're in the trauma bay and you've decided I need to go to the operating room. It's another 30 minutes before you're going to get to this stage. Because you got to get them on the table, you got to wash the belly off, surgical prep and scrub, you got to make the cut, you got to get the cut open enough and the other organs out of the way that you can get down to the thing that's actually bleeding. Sometimes we can pack off with sponges for the entire abdomen, and we can do that pretty rapidly. But again, the transport to the operating room, the cleaning, all those things, even just opening the instruments up can take time. And that's time that's not always thought about when we think about the different steps of the trauma resuscitation. And the key to this, and if you take away nothing else, it's the time from when they're injured to the time where we get to this is the time that you want to think about. It's not just any one of the individual pieces. And so the more you can compress any of that, the more likely that patient is going to survive, regardless of how healthy they are at baseline and regardless of the other problems going on. No, those sponges are all placed in the operating room. The question was whether the sponges are placed before the operating room. The point of this is to illustrate that you actually have to get to the operating room and then do the surgery to open them up and then put the sponges in. It takes some time. So how do we get from one to the other faster? And so now we're looking at ways to shave off minutes. We know the obvious things. You have teams that are created to deal with problems, deal with them in phases. We have pre-hospital, we have the ER, we have the operating room, we have the ICU. You may have heard the think fast, think slow paradigm. And so the idea of this is you build these thoughts or these protocols and ways that you're going to deal with things in your head before you get there. And then that way when you're there, you don't have to make it up again. Again, this saves you a lot of time. Making plans, improving the plans that you've already made, changing your tools to be more efficient, and then changing the playing field, whether that's removing the obstacles in the way, more efficient routing, or changes in your team structure. So sometimes building and teaching teams, so it's helpful to think about it from a sports analogy. Whether you're owner, manager, coach, or player, you may have seen some of these things before. If you've played sports, kids do. We use a lot of things to look at a space and then see how individuals move on that space to accomplish a goal. So this is a basketball diagram. I'm more of a baseball guy, so I have more of these. This, for example, the ball is hit from the plate to the outfield, and there's some runners on, and so this just shows how the players are supposed to move to minimize the damage, right? Again, in a bunt situation, fielders are coming in, pitcher and the third baseman are going to alternate who's going to get the ball and who's going to cover the base, and who's going to cover the second base there. So all these are the things that are analogous to the problems that we have. And even when we're talking about shift situations for different hitters, you're going to move the fielders around to try to guess where they're going to be. Some of these are obviously jokes. And there was one I had to cover up because it was not appropriate. But so how do we do this in trauma? Like, so that, you know, this is nice for sports. It makes sense. The team kind of knows what they're going to do. There's some situational things we try to optimize. So in trauma, some of the challenges, we have a large team that comes from a lot of different places, and this is everyone from techs in the ED to trained nurses to not trauma-trained nurses to the ICU to the ED physicians to trauma surgeons and all the trainees in between that are they're learning the roles. So they have differential experience, and not everybody has done a whole lot of trauma, and some people have. The problems tend to be complicated, or at least when the problems matter, they are complicated. The routine ones, you know, you get a bunch of those, and then you have some that are not routine and require a lot of steps to intervene to successfully save the patient, and those are the ones that are really the problem. Stakes are high. Obviously, people die if you don't do it right. It's time sensitive, especially in these complex cases where you know, you only have a few minutes before they actually crash out, and so like those on the order of minutes to blocks of 10 minutes are the times we're talking about. So we looked at this problem about a year ago and started a program that formalized live drills or trauma process at the Bayview Hospital. So division covers both the downtown Johns Hopkins and Johns Hopkins Bayview. At Bayview, we felt that their response could be a little more efficient than it was, and so this was an attempt to improve those things. So we've been doing it about a year now. The design of this is 6 scenarios. We try to do it as much to drills where we're going to talk it out. This no one knows the drill is going to happen until it's actually already happening, and so the teams respond just as they would in a real one, because again, they think it's a real one until they get there. Now they've been briefed ahead of time so that you don't get down there and then have a whole bunch of confusion about what do I do now, and so that's an important part of the process. But with that, what we do is look at the workflow. You take some data from that. We've done some specific improvements using management techniques that have worked in different industries in terms of automotive manufacturing, nuclear power, and airlines. And then we have a lot of team members, the stakeholders that care about the process that we engage to try to make sure that we're on point, or we're on mission. So this is the trauma bay. This is the one at Bayview. It's the left one. I don't know if you guys have been here or not. There's a mirror image of this one on the right side. These are the initial team members that we have. We have a few more that I didn't have room to list, but these are the core groups that we've been working with in terms of our planning and stakeholder development. And the way that we did it was, again, simulated real-time tier 1s, or this is MEMS alpha designations. And so the scenarios tend to be moderately sick, and this is like an example of elderly fall with some spinal injury that has a subsequent decompensation. So the team has to figure out how to do a chest tube, and then that the patient needs a chest tube to do one, and then they decompensate into neurogenic shock, and then figure that out and treat it. And then the scenarios are all different. We have one about every 6 weeks, but they're all about this level of intervention. So they should take about 20 to 30 minutes to figure out. Again, this is a live drill model, so in contrast to the drills where everyone knows it's going to happen and it's more of a walkthrough and a practice and teaching session, this is geared to test the team that would actually be responding to traumas that day, and that's everybody from the EMS crew that's on, we've had an EMS crew every time volunteer with us, the ED physicians, the ED nursing, and then even we've integrated this to our surgical ICU and our OR staff. So the OR staff come and participate, and they drill at the same time that we do. So we actually roll them up to the physical operating room during the drill. We record all of this using sort of multiple camera angles, and then we do workflow diagrams to figure out, is there a place that we could be more efficient? So the piece of this is we really looked at, with that big stakeholder team, it's allowed us to do these interventions immediately after our drill analysis. So we have, again, this is sort of like fast and slow interventions. And so some of these we see obvious problems that are low-hanging fruit that we can say, we'll just fix this right now. Like we need a marker board here so we can write the things on to take up to the operating room. We need, this cart needs to be moved over here because it's obviously in the way. And then we have that, but then we also have the video data that we can compare in the long term, come back to the group in a formal debriefing session, and then make larger structural changes. And so that's the kind of thing I want to actually show you how we're doing it. There's some of the lean principles that these are just off Google, but to give you a sense of the kind of thing that we're doing. This is designed to create improved reliability, decreased waste, more consistency in the process. And things that are just typically processes that cause you to go slower, to wait longer, to be less efficient. And again, this is all, again, it sounds like a lot of technical stuff, but it's really, again, it's aimed at that amount of time between injury and fixing the bleeding. And this is all ways to shave down the minutes. So this is what's called a spaghetti diagram, and it's an example of workflow analysis. And it looks, again, this is the mess that we saw in that cartoon on the first, right? This is in a manufacturing warehouse. These types of techniques have been used in different spaces. Here's one in another manufacturing setting, and here's one in a clinical setting, used in an outpatient clinic where it's a little more straightforward because it's a smaller space. But you can see on the left, there's a lot of people moving around, taking either a patient or a piece of paper or whatever it is. With that, the team analyzed it and then made these interventions, and now this is the resulting movement. So it's about an 80% improvement in people moving around and getting each other's way. This is just another kind of broad scope from Google that shows you the different things that these techniques look at. But how do we apply that to what we're doing? And kind of bringing it back to trauma. So we made a scale model of the trauma bay. The one in the picture. So I got a little laser interferometer, and we have centimeter precision measurements of the entire trauma bay and everything in it. We got a bunch of video equipment, and we made sort of our data management structure so that this would be something that we could actually do within HIPAA and with other things. Yeah.
So there's a question. Sorry for the lag.
Sure.
If the goal in the hour is until the patient is stable in the trauma center, why wait to activate a medevac consideration only if drive time is 30 to 30 minutes? Shouldn't it be a shorter time frame?
It's an excellent question. I think, overall the goal is really getting that amount of time from injury to definitive hemostasis as short as possible. I think the balancing things on that are, how much resources are you going to commit to that? Are you going to activate the highest, most aggressive transport for every injured patient, or are you going to pick and choose the ones that look like they're going to be more injured? How much or how long do you wait to do it? I think those really important questions to address. This is a little more key to once they get to the hospital, how to shorten that time. But anything that can be done to shorten the time within a reasonable, respectful to resources paradigm would be good. Again, not knowing the exact situation of that context, but yeah, the goal is to shorten the overall amount of time. The way that we ended up analyzing this is we used essentially a CAD program, the Illustrator program, which allows us to take measurements on a fairly precise way, and we are actually looking into automating a lot of the process, though we're doing it manually right now. So this works, and I think this is the video. I should be able to get it to play. Here we go. Maybe. And so this is just an example of our recordings, and this is the scale model that we have. And you'll see as people start to come in, the team is tracked as go throughout the process. And so this is at every interaction. This is when they move up to the patient, move to a supply cart or whatever that is. And obviously this is just for one individual, and there's somewhere between 10 and 30 people depending on the trauma. And so in our drills we do this for all the participants. And so it becomes a little more busy than this. But this should give you an idea of at least the kind of situation that you're seeing. This is, again, the initial drop-off and when they're doing their first part of the primary survey, and how much moving around that you'll see. So when we did it the first time, we didn't do any intervention. We just let it run, see what would happen. And this is what one of the diagrams looked like. This was pretty simple. So it was a lot of, you can see first moved around the entire bed a bunch of times. They moved a cart up, they moved here, they went out of the room, went back. And it's a whole lot of movement for not a lot of action. The surgery resident was doing, he was the one that was sort of doing the primary survey exam to get supplies, was going back and forth. And this is their team member here. It looks like they were doing a lot there, actually just moving back and forth, doing anything. We measure this in meters because it seemed to be the primary nurse walked a couple hundred meters. Resident walked 100, and the junior resident, who was not doing much, walked 50. And so we looked at where they were actually walking. So this is the blood storage cooler, the supply carts, the medication pyxis, the different arms where they were trying to get access. The texts were a different pattern that I'll show you here in a little bit, which was more aligned with the junior resident that we have a pretty impressive turnaround on. But so we looked at all this data, we did a formal analysis and debriefing. We felt like the tech role was poorly defined. The primary nurse was being way overutilized, so she was doing all the work, or at least a large portion of the work, whereas there were other people that were kind of standing around and trying to stay out of the way, and we felt like if we had the personnel resources, we should at least balance them more. The layout and what was actually in the supply carts, we felt that could be improved to reduce the need to run across the room. And the group itself had a very different understanding among the different members of the group as to what they should be doing. So, what do? We revised our actual policy in the hospital on what the roles and responsibilities of each of the trauma members were supposed to be. We've fed this into an education program within both the surgery residency and with the emergency department nursing. We got formal training for the emergency department nursing and trauma, so the ATCN. And we adjusted the supply cart stocking plan. So the layout of the cart and what was in the cart was redesigned. Again, with that, going back to that Pareto efficiency, the 80-20 rule of this, the cart should have everything you need for 90% of the trauma activations. And so, hemostasis supplies, central lines, IV equipment, tape, and we took out the things that you don't need urgently or that you don't need very often. And so that way that small cart could be positioned in a more optimal way. And this, yeah. Say it again.
What did you do with the stuff you removed from the cart because it was only used for freezing?
What would we do with the materials in the cart that were only intermittent? So the stuff we anticipated to suddenly need was all in the bedside cart. We had an emergency cart for things you would need really fast, but not very often. That would. I'll show you on the next diagram. And then for the things that were uncommon and not time sensitive, then those were in carts that were slightly farther away. So the other things we looked at, path length, which again shouldn't be thought of as an outcome, but as a metric for the efficiency of the entire process, and gives us something that we can actually intervene on that will save time overall. So we did look at the times though, so time to complete the primary survey, time to the initial IV access, time to CAT scan, OR, X-ray, etc. So just to answer your question, this trauma supply cart in the back is the emergency cart that's not needed very often. What we did, these initial IV supply carts are the ones that were down here that we restocked, and so the way that we changed some things around, these were moved up to the bedside, the monitor was moved over, and the roles were slightly rearranged. So now we have the primary nurse has primary access to this bedside supply cart, the monitor, and the patient. And we split the roles of the surgery residents on one side or another, and so they can help across the table. And then secondarily, we added a pathway for the cart to come in and additional support as needed. And so we had ICU nurse coming down, which was a new thing, RN assistant and tech positions on the opposite side of the primary nurse, again, to balance out across the bedside if you needed to grab something, hand something across. Again, this is space you actually had to move around. It was supposed to reduce the amount of times you crossed over and got in each other's way in these, about and transfer appropriate high utilized person to a lower utilized person to balance everything out. So much like those sports diagrams we were looking at before, this is meant to kind of give the team a sense of where to go. And so instead of the primary nurse having to go over here and over here, we put the majority of her tasks, or his task, here. The primary resuscitator, which is ED resident, surgery resident, or other NP, PA kind of person, on the opposite side where they have full access to the patient here without getting in the way of the primary nurse. And then we have secondary support from another NP, PA resident and another tech or nurse on this side, which have access to these other less commonly used but very important supplies, and while maintaining protection for the primary nurse on this side, and vice versa for the primary resuscitator and the secondary, who has access to these less used carts on the other side.
Who made the decision on what things go off the cart that was sitting in that primary?
Say it again.
Who made the decision? Did she have a part of it, or was she the main focus of the decision?
So all these decisions were actually made with that consensus group. We had a working group that was like a single or two representatives from each, and we would do that all in concert. That's I think the reason why it was so successful, and we were able to implement as rapidly as we did, is we actually had input from everybody that had a stake. Interestingly, it appears that we were more efficient with fewer people, which we didn't change the total numbers of that because it was somewhat of a fixed quantity in our staffing models. And so while that's something we could obviously adjust, it would take more altering other plans in the hospital or the ED staffing and things like that, where they deal with non-trauma as well. So this was all just redefining the role of who showed up to the trauma rather than changing it. Really something to think about. So again, this was the first drill. This was the text in the first drill. Again, a lot of this is trying to stay out of the way, not really knowing where to go. Here's where we were trying to get people to go, or the primary nurse role to be focused. And for the tech and the secondary role were designed to focus based on the new layout. And here's what happened. So this is drill number 2. You can see there's increased density here in the movement pattern. Get the bedside cart, which is the updated supply cart, the monitor, and the arm of the patient. There's a few of these. Some of this is moving out of the way for the X-ray machine to get in. Some of this is going out to the CAT scan and coming back. So these long loops down here or that. And then again, for the secondary assisting nurse on the opposite side of the bed, they're clustered here. Drill 3, we actually see increased density and colonization on both that side and the other side for the assisting nurse. Drill 4, similar things. The assisting nurse in this case was running to get blood and other supplies from the closet, while primary nurse was doing the majority of the interventions on patient's right. Drill 5, similar patterns except reverse. So patient's left ended up being the more demanding side, while the patient's right, we had high amounts of clustering, and the nurse didn't have to move and dodge other people and that kind of thing. So the tech roll, this is the second from that initial messy diagram. Now there's some movement all around here. It's a little deceptive because the path length of this was about a quarter of what it was in the first one. And the amount of time it took to do this was about a minute and a half versus 20 minutes for the first one. This was, with just a little bit of orientation, we had a substantial turnaround in people knowing what they were supposed to do, knowing how to fit into the team in a kind of flexibly changing situation. Again, just to review, that's where we were intending on the right and then the left side for nursing and tech roles. For the residents, this is the third drill data. Again, you see some clustering here and here. And then drills 4 and high amounts of clustering. Drill 5, larger amounts of clustering here. Drill 5 was a little different because there was an extra person that showed up and then they stood at the bottom and walked around. It helped a couple of times, so mostly we're trying to stay out of the way. So for some of the other roles, one thing that surprised us was the trauma leader. This was usually the ED or trauma attending physician. There was a lot of ability to exchange roles here, and so what we saw in the drills was in multiple situations the role of the leader running the trauma would swap between the ED physician and the trauma, and this could be because one is doing a procedure and they then would hand off to the other one to run it, or it was a short arrival time and then it took some time for the other person to get to the trauma bay. But it was stuff that we didn't anticipate finding, which was kind of the interesting part, that it happened so smoothly. And then this is illustrating another adjunctive role from the ED resident, which is managing the airway primarily. So this is, when we looked at the actual distances over time, we had the yellow bar is the most significant here because this is total nursing workflow. And this was obviously the biggest number that we were dealing with to start with, and now we're a little less than 40% of that. The orange bar is the next bar to really look at. This is the resident workflow, or the resuscitator workflow, people doing the primary and secondary survey. And we had significant improvements here. On the drill 5, you see a spike up, and that largely was attributable to that third person, the extra person showing up and walking around. But we included everybody because we wanted to be systematic about it. This is when you look at the amounts of time to those certain goals that we were talking about before. Again, time to getting your IV access, time to taking them to the CAT scanner, time to finishing your primary survey, and time to making that decision to do they need to go to the operating room or the ICU, and then time to actually leaving. This is the progress. I would say the most important bar here is the blue one on the top here, and the blue one on the bottom. Now the blue one on the bottom was fairly consistent, so we didn't see a whole lot of changes there. Again, a little bit longer than we would like the primary survey to take, though some of these are variable situations and it's a little hard to hone out whether that's efficiency problems or if it's just scenario differences. The top one, you see there's this spike up on drill 5. The interesting thing about drill 5 was it was actually a double drill. So the first part of that scenario was a routine came in after a bicycle crash, seemed uninjured. After a standard workup, they were then taken to the CAT scanner and then had a aspiration event in the CAT scanner as part of the drill, and came back to the trauma bay and essentially started over from scratch. So they have that you can actually see this time to transport the CT. This was really the marker for the initial evaluation, and then if you adjust this for that time when the aspiration event occurred, this is the times on that fifth drill. And so we actually, when we took out that first part and had them deal with a more acute scenario, the times were substantially improved. And so this is, the red line just represents a 15-minute mark. And notice where we were when we were starting up here. And then even by drill 3, there's substantially better times, to transport for sure, and then for definitive care on the end here. This is just the same graph represented slightly different format. And then when we talked to everyone that participated in the drills, we got overall fairly positive feedback and found some things we weren't necessarily expecting. The simulation is a fairly low budget simulation, and this is intentional to make it easier for other types of teams to do it and to make it more applicable to situations that aren't just trauma. Again, we're looking at things like emergency airway teams and blood bank process with the same analysis techniques. We had some feelings that the responses were scripted, and some of that I take as a compliment because our team knew what they were doing well enough to appear that they'd rehearsed. The timing was felt to be better. The role knowledge and understanding was felt to be better across the progress of this project. And the availability of equipment was felt to be more intuitive. And so this is in the context of every month, the whole staff turns over to a new staff that may or may not have ever been there before. And even with all that, we were able to see consistent progress and consistent subjective improvement in how people felt about it when we asked. Handoffs were thought to be good, and transfer of tasks was felt to be good. The patient was felt to be safely cared for. But there was also comments of it was very crowded, communication was hard, even though it was good. Again, a little bit of contrast. The consensus of the team on what was actually going on with the patient was not always there, though it did appear to be improved by the fourth and the fifth drills. So there are some things remaining regarding the operation side of the drill, of making sure everybody's aware, making sure they know what to do. These have been improving over time. As we get more experience with it, we have pretty good buy-in from leadership within all these departments. Just communicating that out through large workforces that rotate frequently is an operational challenge. So the patient experience, something we didn't anticipate learning about, but we did actually found out a little more than we thought we would. The volunteers for the drill, so the patients, quote unquote, that come in are employees of the hospital that volunteer to be brought in on a stretcher. They have makeup to simulate the injuries, and they act out the scenario. All of these patients, without exception, had a profound experience doing this. Even though this is something they've all had a lot of trauma experience and taken care of patients, but I think the amount of confusion, of not knowing what's going on, of being rolled naked through the hospital was something that impacted them a lot more than we thought. There was a lot of, at least from their perspective, a lack of clarity of who was actually in charge. There seemed to be multiple people doing things of which they could only see one or two. And it was a fairly scary experience, even in the context of knowing it's a drill and knowing how trauma works. So we felt like there might be some opportunities there to help that patient experience through the process. The interesting things, again, the role flexibility was something that we thought was a resource that we hadn't anticipated. The ability of the different people with different training paths or different amounts of training to fill roles that they weren't necessarily designated for was fairly robust in the drill. We were able to change the team dynamics by altering the structure of the trauma bay and the stocking of the carts and that kind of thing, and so that it was more intuitive to do it the way that was the most efficient, rather than it being either unclear or more obvious to do it a way that was less helpful. But there may be some opportunities to improve here. So we're developing more roles for the surgical ICU to directly participate in the trauma, which is about 80% up and running now. Back channel communications or secondary communication lines for when your anticipated person to call is not answering the phone are things that we've found are issues that we need to work on. And the frequent turnover of nursing staff residents, and other participants of the trauma teams is an ongoing educational challenge that we've been having some success with, I think, with just persistence in the process. So the simulation quality itself, make up models of these procedures that are not designed to be test of how good you are at the procedure, but are mimic the steps of a procedure. For example, putting a peripheral IV in, we have a little model that has veins, and then you put the IV in the vein. It takes about the same amount of time as putting an IV in normally, and we can actually infuse fluids through that. We have a similar model that we make out of an IV bag for a central line, so we can put a cordis line, and those big resuscitative lines in, and use the level 1 rapid infuser and put fake blood units in. So we dye some saline bags red and put them in the freezer and bag them up like real blood, and so we simulate that cognitive process to at least prevent these state breaks where it's like, I'm in a drill, I don't know if I can do this or not. So we try to reduce that as much as possible. The knowledge of where these new equipment things are is still pretty left to be desired. And we have instituted some monthly training to help remedy that, though I think the fortunate thing is, even though people don't know where the equipment is, when they look in the first cart, it's all there. So that's good and bad, I guess. So other improvement things, we're looking to get more IO guns or IO drivers for the trauma bay to make them more available, so we can put them in those carts to improve our simulation quality, improve the layout in some of these other subtle ways, and then refine our roles and responsibilities a little bit more. The major challenge, I think, to progress in any team situation, I think, is having consistency of your team and commonality of training in the team, which are things that we can work to address. But obviously there's other equities involved here, including you're training not just trauma resuscitators, but you're training for an entire ED, a large hospital that has, responsibilities that include things that are not trauma. Let's see, I think I went back too far. So we did do a lot of various scenarios during the drills. Downtime, so our EMR wasn't working for one of them. We had decompensation and transport. We had the elevator not work. All these procedures were sort of tested within the workflow process. And we've learned a lot. So I think, yeah, you have questions?
Can I ask, what is your threshold for using an IO in trauma patient versus an IV?
I use it fast, I think, and that's the consensus recommendation for ATLS now as well, is if you fail your first attempt with peripheral IV, IO is the next go. I think the goal is, again, shortening that time. We've had a lot of patients where historically, it's like, well, I think I can get it, and it's try again, and it ends up being half an hour before you really have access. From my personal protocol, it's, working IO, and then if they need active resuscitation, they get a big central line.
Did you have any feedback from the EMS crews that were involved in your drill?
We,
Doing better?
not so much feedback to them, but we got feedback from them for each of the processes, and a lot of that was pretty valuable. And actually, one thing I would be interested to hear is what the common experience is among these scenarios where you're dropping off a patient that's fairly sick. How much, on our side of this, a lot of times the information, the amount of sign-out time is the critical piece there. And it's how do you take the, lean essential information that needs to come over, and how do you choose what that is, and then get that communicated within a, short amount of time. I'd say most of the time our experience is pretty good, at least at the, downtown and the Bayview locations. But I would, love to hear what you guys think. I know there's a sense that I think there's some opacity to the process of once that drop-off happens. Yeah, thoughts?
Two things I can think of right away is that our trauma categories don't mesh with each other.
The memes in the hospital categories.
The delta is for you.
Yeah.
what it is for us is
Yeah.
different. And then the other thing would be, who are we talking to when we come in the room? So if somebody immediately says, I'm in charge, we have, that would be helpful.
That's a good feedback point.
Can you repeat that?
So yeah, so the thought was that it's difficult to know when you're bringing a patient in who's the person that actually needs to get that information, and so somebody saying I'm the one to sign out to or I'm in charge would be a helpful thing. Yeah, I mean, I think that's something we could certainly easily implement. And our trauma category, yeah, between the memes and the individual hospital categories. So interestingly, even between Shock, Hopkins, Bayview are all different in terms of how they classify their traumas as well. Yeah.
I was just going to say, do you know if there's ever, is there going to eventually be a universal category?
I think there are a lot of people that are interested in some universality to that. That ends up being a real big thing if you're going to do it across state lines. Right now, the hospitals have chosen to kind of maintain their own ability to do that based on their own resources and how they want to triage. But I think, the more consistency you have in the process, I think the less confusion. Yeah, that you're going to say something.
My question just had to do with your trauma categories.
Yeah.
I know probably 8 months to a year ago, it used to be like an echo, but now it's the tiers. It seems like it's
Yeah.
changed quite a bit. What was the driving force
Yeah.
behind that?
So the question was at Bayview, there was a recent, or about a year ago, there was a change in the way that we classified our severity of traumas. Historically, the Hopkins trauma system is used Delta as the most severe trauma, Echo is the second most severe, and I think Alpha's for pediatrics. I'm not sure about that one, but at Bayview, it was felt that this didn't adequately reflect the population that came in, and there was a large group of patients who appeared to be not severe by those triage categories that ended up having significant injuries, namely people with severe intoxication and elderly patients on anticoagulation with a fall. So lots of head bleeds or missed injuries or potentially missed injuries. So it was reorganized into a system that was Tier 1, Tier 2, Tier 3. The names were a little bit arbitrary, but I think chosen for expediency and to be different enough that people would know that there was now a new category. Essentially, the Tier 1s are just like the old Deltas, which is, I think, like your memes, Alpha. Tier 2s are the less acute, but still acute trauma, so like the old Echoes. And then Tier 3s are like a different thing, where it's suspicious mechanism based on those categories. Again, severe intoxication, elderly patient on anticoagulation, that kind of thing.
You obviously learned a lot and saved a lot of time with this study. I'm just wondering, all traumas are different, but in general, how much time does that give us in the field to get that patient to you? And how much time did it take you to stabilize that patient and make it safe?
I'd say for most traumas, a routine, moderate severity, moderate complexity, once they get to the hospital, we should be able to get them ideally to definitive care, whether that's the operating room or the ICU or wherever it needs to be, within 15 minutes. Now that's maybe a lofty goal, but that's what we were able to accomplish in the last 3 drills. For something that's more complex, where you're going to need more intervention within the trauma bay, again, that time's a little bit longer. Sometimes it can be as much as an hour or even longer. In the case of multiple resuscitations, having to put lines in, having difficulty with access, that kind of thing. Even still, I think there is room enough to improve to get that down to less than half an hour. From an outside transport standpoint, I think the sooner the better is generally what we think. I think in my head, the critical decision is, if you're whether they need to come or not, which obviously can be difficult. And if the decision to bring them, I think most of the data suggests that the more quickly that person is brought, even at the cost of some intervention, the better they'll do. And I think there's some exceptions to that, whether it's glucose or, if you try to get an IV or not, or something that's easily kind of fixable. But I think the thing you want to avoid the most is spending a lot of time on workup, especially in the case of, gunshots or stab wound, penetrating trauma, that kind of thing, because a lot of these people can look totally fine until they crump. I've seen people like yelling and cursing at me and throwing punches, and then like 5 seconds later they're in cardiac arrest. And you never know who that person is, because it's very hard to tell the difference between somebody that has a gunshot right here to the middle of the epigastrium that goes in the subcutaneous tissue and doesn't do anything versus one that went through the aorta, until you actually get them in and do your imaging and stuff. And there's just really no way to tell that otherwise. And so going quickly in those sort of higher risk situations, I think the faster the better. Yeah.
What's your time frame of notification for the crews to assemble the team? So if they got a 10-minute transport time from the hospital.
I think 5 to 10 minutes is ideal. If we get notification more than 15 minutes, it can sometimes, and this is probably more of a hospital issue than for you guys. I think the calling earlier is generally a better rule. But for the teams to assemble, sometimes about 10 minutes is the golden. If it's too long, then people kind of stand around and forget why they're there and get pulled away from other things that they're doing. But that's what we like. Often, especially at the downtown campus, our lead time is about 1 or 2 minutes because of the short transport distance between where somebody got shot and where they come in.
I wonder what we see as opportunities to, I think that we all have the experience of taking patients into the hospital, whether it be a cardiac arrest or a trauma, and we know, right, they're on their game, right? They've got roles, they've got specific delineated kind of what's going to happen, and it goes smoothly, right? So I think we all recognize the difference in that. I wonder what our reflections are about what a cardiac arrest or a trauma looks like in the field, right? Similar to my take on what the fire side, right? When the first engine comes, they do this. When the second engine comes, they do this. When the third engine comes, they do this, right? I wonder whether you guys think that we have similar structures and roles for critical events, whether they be cardiac arrest or a trauma. What do you guys think?
Nothing's carved in stone.
Okay, again, I'm sorry.
Nothing's carved in stone.
Nothing's carved in stone. Do you think that we have a rough kind of roles and responsibilities?
Yeah, so I think what you're thinking is to assign as needed.
Assigned as needed.
I think a lot of it can go back to the pit crew theory back when they started with the high efficiency CPR, and everybody pretty much had a defined role. But then again, you still can cross roles. Yeah.
That's one thing we found as well, that role flexibility and knowing who can transition where, I think is a really important part of having a flexible team that can deal with different staffing. And
I think people too often don't know what their role is up until a cardiac arrest in the trauma, or any other patient for that matter. So, we could certainly start assigning some roles that would fit into the generalization of trauma, not being too specific.
And how much do you think we do in terms of training and establishing these roles and reinforcing these roles, right? So we do pretty routinely, we do mock codes in the hospital for sure. You hear these elaborate kind of efforts to standardize what happens in a trauma, and God knows it's needed, right? I wonder how much our opportunity is for us in terms of training. And maybe a lot happens and I'm just not aware.
We can definitely improve on that.
It all comes back to time, having time to do it also. I mean, sure, there's definitely time we can find, but, to get a medic available for training is tough.
that's one of the challenges we ran into this as well is, our staff are, they're there 80 to 100 hours a week, and they're like, every minute that they're there is almost consumed with something. And so we designed something to fit into the workflow as it was without having to have them take a break out of their other obligations. And so the way we protected that was to make these compact enough to not take longer than an actual trauma that might come in. And that we tend to target them at times where we know that some of those resources are available. We have abort plans for patient safety, like if the resources are already strained, then, last week we aborted one at 4 a.m. because there were 2 OR rooms running and the trauma team was all tied up and that kind of thing. But fitting it into the workflow and having the live drill model was deliberately chosen versus a large planned training event for that reason. And then there's some targeted feedback could be included or not as you'd like.
It's also not quite possible for that. I mean, we work with different units every day. We have, 4 different shifts or 5 different shifts career-wise, and then, with the volunteers, you really never know who's going to be on the unit.
Yeah.
It's a different team every day. So you do see the same people a lot if you're in the same area, but it's very difficult to train and then expect a result that's going to actually mimic results.
Yeah, that's exactly the problem we were having.
Keep doing the same drill. For us, I don't think that that's something that we could repeat.
Yeah.
Then we also have the problem that you guys are all in the hospital waiting for us. Like, we all arrive at different times on the scene, so that's really hard to assign roles, because what if, one person is not seeing it?
Yeah, believe it or not, we have the exact same problems. As these guys that are in the trauma team, in most hospitals, there are some exceptions to this, but in most hospitals, they're actually fulfilling about 6 or 7 different roles for any one person, whether that's the ED nurse, whether that's the trauma resident. And you don't get the same team twice in one day, even though, you have the same larger group of people working there, just because there's, 1,000 people in the hospital working at any one point in time, and 100 people that might be part of the trauma team. It all shifts and interlinks. It is a very difficult problem. Much appreciated.
But I do think that, typically when you talk about standardized training and even simulation labs and, in other industries and in healthcare, I still think that there are opportunities to standardize and to create that training, because I don't think that it should matter who the team lead is, right? I don't think that it should matter who's driving the medic. I don't think it should matter who EMS, who the EMS district officer is who shows up, right? I think that over fire ground, my take, and certainly within healthcare, I think that, when I show up at a code at a hospital, I have a role and responsibility, and the person that I sign off to, at 6 o'clock when they take that picture and they show up, they have the same roles and responsibilities, even though we're not the same person, right? So I still think that there's opportunities, and similar to when we do high-performance CPR, right? There are still principles associated with that and roles and responsibilities that I think that we could continue to grow with, right? And I think that there are a tremendous amount of educators within the fire service who are passionate about this, and I think there are a tremendous amount of frontline providers who believe in this and who have done an extensive amount of training. So I think there are, just a matter of, do we want to prioritize that as an opportunity for us to continue to build upon these experiences?
Yeah, question here.
I feel like in the field, we actually kind of have something like that in place as far as a cardiac arrest situation, especially with our SOPs, because for one, we have one that kind of outlays like the role of each provider. So like our captain, for instance, would be the person getting like the patient information. The theta will be the person in charge of logistics as far as getting the patient out to medic, getting the medic like positioned properly. Like your first paramedic on scene would be like your meds and monitor, your EMS supervisor, airway, like that kind of thing. So we already kind of have something in place. Maybe it's just underutilized.
So I think we've all seen variation, right? We've been at codes in the field that go exceedingly well, and they're smooth, and everyone's got a roll, and it goes, and then sometimes.
We talked about
Little bit crazy.
the time required to start an IV, and I think in category A's and B's for EMS, we do a pretty good job leaving the scene quickly. But when it's a C or D, and this is just tradition, we always start an IV on an ALS patient. But if there's so little reason that we even need an IV in a trauma patient anymore, not giving fluid like we used to, that if you all already have a plan to get access, then we can probably just say, you know what, do we really need an IV? No, we don't. Let's just hit the road, because that's 5 potentially longer minutes saved right there.
Yeah.
That's like the lowest hanging fruit.
I think that's a really good point. A lot of times, even with a good IV, around and transporting, a patient that just reaches over and pulls it out, like I'd say, just anecdotal in my experience is IVs that even were working in transport, maybe 30 or 40% fail by the time they get to when we need them. It's nice to have, obviously, if you got one, it's great, especially if they need intubated or something like that, right on arrival. But I think especially if there is increased utilization of the IO as a second access technique, which is, again, what our standardized training has moved to in the last year, then I think that might save that time on the front end.
Sure. I mean, if you guys are just comfortable with an IO, and I mean, in kids, we just go right to that. And probably,
Yeah.
so
Yeah, I think iOS gives us I think of we have two kinds of access. We have the meds access and we have resuscitative access. And, a 20 gauge IV in any location is just meds access. And resuscitative access might be okay with a couple of 14s, but maybe not in a really bad bleeding patient. So they usually need more if they're going to need resuscitative access than is feasible to get in transport anyway. Just having any kind of meds access, even if an IO is great, like we just take them out when we're done with them.
What's your progress when you guys use an IO in traumas?
Either tibial or humeral head. And both are pretty easy. Like if they've got broken legs, then we'll go up top. I think legs are a little easier to get to because there's a lot of people standing up around the head and the arms. But either one's fine.
I think, what are we emphasizing now?
I think it's a little easier to put in a humeral head one, but
Definitely advocating for
yeah, I don't think it hurts as much to put that in without other stuff. The tibials hurt.
anything else that we could be doing better?
I'll keep it up.
Well, not necessarily what we could be doing better, but kind of what you guys, when you talk about EMS practice, kind of what are those things that are so important?
You just gotta get better at moving faster. You got a lot of older EMTs like me around, you got newer EMTs. Sadly, you'll get better at this when you lose somebody because you realize you weren't fast enough the head-to-toe assessment. We have to get better doing a head-to-toe assessment. Sometimes you have to look at the paramedic and go, we're going. And it's not being disrespectful, we just have to know what they can do and what we can't do. They would say we can give these, we put them safely, not say swoop and scoop, but do that primary assessment the best you can.
Yeah.
You know how to do a blood pressure by palpation. You know how to do lung sounds, abdominal sounds. Clear the front, clear the spine. Collar, go. There's nothing, sadly, all my years in combat medicine, you will get better at this when you realize you lost somebody because you're looking in the ears for cerebral spinal fluid. You didn't have a flashlight. What are you doing? We can learn better from trauma centers. Back in the 80s, when we took patients to trauma centers, we would get a report back. What did you find that we didn't find? Or did you happen to find what we found?
I think those feedback loops are really important, and not even for outside the hospital, especially even within the hospital. I think a lot of times the emergency medicine guys don't get those reports back, and so there's very little in the sense of did we do it right or not? Did we lose somebody or did we not? We try to do that intermittently. Our workflows have not really been conducive to it. But I think from a leadership standpoint, that might be something really important to focus on. Across the entire spectrum of trauma care. What could have been better? What actually ended up happening? That kind of things.
And also, we do a consult. Why am I repeating it?
Yeah.
We give a. But sometimes.
May not need to be.
Not in the trauma bag.
Yeah.
So it's stark.
Yeah, I'd say a fair amount of times, and I don't know, I wouldn't guess at the percentage, but the report that we have on our consult sheet and then what is said verbally when the team comes in are somewhat different. And I don't know if that's because the situation changed or because the interpretation of over the phone was not accurate or there, some garbled among the process. It's hard to know. I think, to your point about, when you lose somebody, I can tell you the most frustrating experience I have as a trauma surgeon is when I'm in the operating room and I've stopped the bleeding and then they just die right in front of me. And that's because their heart ran out of juice. And if I had 20 more minutes, we could have been out, we could have been fine. Or getting there and you get everything fixed and then they run out of clotting factors and just start bleeding everywhere because they've used them up. And oftentimes that's a matter of minutes that you need. And when you miss it, it's real hard. Yeah.
Do you guys use TXA in hospital?
Yes. The question is, do we use TXA? Yes.
TXA these changes?
In Ohio, where I was before I came here, the part of the EMS protocol and major trauma was TXA in the field, and we repeated the dose when we came. I'm not sure if there's any interest in that here with EMS or not. But.
The person that's doing the consult, do they log what's going in, and does that go to the person?
Yes.
They said something about, they were logging it, and it was right there, so that when they came in, the doctor knew exactly what they had.
We get, so there's where they take the call and where the trauma bay is across the hall. There's a little paper form they fill out with all that.
So there is a paper,
Yeah.
okay.
There is some, again, even with that, there's still some inconsistencies, but we generally have an idea at least of what it is. Occasionally the severity is not concordant, but again, it's hard to know how much of that is lost in translation or if it's evolving patient over time or whatever it is. Anything else?
Thank you, sir.
Yeah, thanks guys, really appreciate it.